name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 6 of this cardiology series, where today we're going to be talking about atrial fibrillation. Before we get right into the video, I just wanted to say I've really been enjoying doing these videos recently because it helps, for one, keep my knowledge up to date, and then also for you guys, it might be useful in if you're learning something new, or if you're trying to simplify a complex topic. So with that being said, let's get straight into the video. So, like always, we need to talk about some definitions and also the classification of atrial fibrillation. So the definition is, it's disorganized atrial depolarizations without effective atrial contractions. And essentially the cardiomyocytes, so the cells of the heart, contract independently, leading to fibrillation. It's the most common arrhythmia. So an arrhythmia is an abnormal heart rhythm. A normal heart rhythm is called sinus. And if you looked on an ECG, you'd see a P wave followed by a QRS complex, and that's known as sinus rhythm. It's also a supraventricular arrhythmia. There are lots of other types of supraventricular arrhythmias. I'm going to talk about them in future videos and how to identify them on ECGs. I'm going to be doing an introduction to ECG interpretation in the next video. Other definitions. So this is more to do with the classification of atrial fibrillation. So we have fast AF, also known as rapid ventricular response AF, and it's essentially when the pulse is greater than 100 beats per minute. So when you have the atria contracting very, very rapidly, and the atria can contract up to rates of greater than 300 beats per minute. You have the electrical conduction going through the AV node, and the ventricles can pick up the electrical impulses and then essentially have this rapid response where the ventricular rate can end up being above greater than 100 beats per minute. We also have slow AF as well, and that's where the pulse is less than 60 beats per minute. So with AF, you don't necessarily have to have a high or be tachycardic. You can also have slow AF too. And slow AF seen in things such as hypothermia, digoxin toxicity, in medication errors, and typically elderly patients with sinus node dysfunction, so dysfunction of the SAN. And sometimes that's called sick sinus syndrome. That can present in various ways with tachyarrhythmias or bradyarrhythmias. So that's just something to be aware of. And then we have paroxysmal AF. So that's where you have recurrent episodes greater than or equal to 30 seconds, which end suddenly or with intervention within 7 days. That within 7 days is quite important. And with AF generally, most patients tend to be asymptomatic, so they don't have symptoms right away. We have persistent AF, and that's AF that fails to end within 7 days. Okay, so we've got it lasting longer than 7 days. Long-standing persistent, which is where the AF is lasting greater than 12 months. And then permanent AF, which is where patients, where sinus rhythm, so remember that P wave followed by the QRS, can't be restored or maintained. And the atrial fibrillation rhythm is the final accepted rhythm. I'm going to talk about more of the ECG features of atrial fibrillation later in the video. And essentially the reason why you have persistent AF, why it continues, is essentially because you have calcium overload within the cardiomyocytes, which leads to fibrosis, and basically maintains this fibrillatory process. Okay, so let's talk about the etiology of AF, so the potential risk factors, causes, etc. And The etiology is essentially related to factors which promote an inflammatory state or stretching or distension of the atria, and kind of put strain on the atria. Um, yeah, and when you have atrial strain, this further causes atrial more dilation, which maintains the AF. So it's kind of a almost like a positive feedback where it's maintaining itself um, through this atrial strain. And the most common associations are typically obesity, alcohol, and hypertension. So in terms of cardiac causes, we have hypertension, which we've just mentioned, valvular heart disease. It could be typically mitral stenosis or mitral regurgitation. Particularly mitral regurgitation, you can have a backflow of blood into the left atrium, and essentially because of the increased pressure, the atria, so the left atrium distends, and that can contribute to the AF pathophysiological process. I've also mentioned sick sinus syndrome already. You see that in the elderly, and that can lead to slow AF in particular. Or another type of arrhythmia called Wolff-Parkinson-White syndrome, which is um, an arrhythmia called an AVRT. So I'm going to talk that's another type of supraventricular arrhythmia, which we're going to talk about in more detail in another video. And then things such as congenital heart disease, myocardial infarction. So the AF, in that sense, happens secondary to heart failure, because of basically congestion of blood within the atria, which leads to that distension. And then other things such as cardiomyopathy, myocarditis, pericarditis. So a range of things affecting different parts of the heart. Okay. And then you might have seen this diagram in some of my other videos, and it's basically just outlining how hypertension can lead to the development of atrial fibrillation. So we know that in hypertension we have an increased systemic vascular resistance, otherwise known as afterload. The heart tries to overcome this by through left ventricular hypertrophy. Uh, you also get a shift of the baroreceptor reflex, pressure natriuresis, other compensatory mechanisms to try and lower the blood pressure. However, you get blood backing up into the lungs, and the heart, the pump, is unable to meet the metabolic demands of the body. This is known as congestive heart failure, and essentially the atria distend, very important word, distend, because of the elevated pressures, causing disturbance to the heart's electrical pathway, and essentially the result is atrial fibrillation. Okay. And then we have some non-cardiac causes here. So we have respiratory causes such as COPD, pneumonia, pulmonary embolism, obstructive obstructive sleep apnea, essentially where there's increased sympathetic activity in OSA. Other respiratory um, conditions typically affect the right side of the heart first, so the right atrium. They're going to lead to right atrial strain, and that can present with particular ECG features too. So a right-sided strain pattern. We have endocrine causes such as hypothyroidism, diabetes mellitus, acute infection can precipitate AF, electrolyte derangements, hypokalemia, hypomagnesemia. You have to be aware of hyperkalemia as well. Hyperkalemia is a big risk factor for other arrhythmias, such as ventricular tachycardia, which can develop into ventricular fibrillation, which is a very serious problem. CKD, infiltrative conditions such as sarcoidosis, amyloidosis, certain drugs. Excess caffeine is an important one. Caffeine can, excess caffeine can produce these paroxysmal AF episodes in particularly susceptible individuals. We've already mentioned obesity and increase in age and male sex. Okay. So let's talk about the pathophysiology of atrial fibrillation. And at the moment, it's not really fully understood, but there's various theories which try to essentially explain the mechanism of the pathophysiology. Um, but essentially, what you have is a disruption in the normal electrophysiological mechanism of the atrial myocardium, the atrial muscle. And we have two theories here. We have an automatic focus theory and a multiple wavelet mechanism. We also have this nice diagram here, which I'm going to mention in a second. So the automatic focus theory is when AF originates from an area of focal, so focal or localized electrical activity. So this is essentially when you have conducting cells of muscle, myocardium, heart muscle, surrounding typically the pulmonary veins, and these this muscle, this area of focal activity can produce ectopic atrial topic electrical activity. Because remember, the electrical activity of the heart should be originating from the SAN being transmitted um, to the AVN down that kind of regulated pathway. It shouldn't be happening elsewhere at an ectopic site, such as around the pulmonary veins. Um, and then we have these maintenance mechanisms. So in this first theory, the automatic focus theory, there isn't actually a proposed maintenance mechanism. And it's just important that I kind of clarify what that actually means. So essentially um, the area of focal activity is a trigger. So that's that initial ectopic focus of rapid firing. And then maintenance is typically when there's an alteration in the myocardium, which enables the abnormal or conductance of the abnormal electrical activity to continue. And this is typically when there's structural remodeling um, or like fibrosis of the myocardium due to impaired calcium handling and due to another thing called refractoriness. So that's when there's insensitivity to the electrical impulses that normally control the heart's rhythm because of these kind of ectopic pathways. You might have heard the term like re-entrance circuits, and they can be kind of maintained by these by the fibrosis. What happens due to the calcium overload within the cardiomyocytes? Okay, so let's talk about the multiple wavelet mechanism. So this is essentially when spontaneous waves of excitation become fragmented. So this is saying that you've got lots of different sites of electrical activity, not just around the pulmonary veins. And it's based on the idea of lots of re-entry circuits which maintain the fibrillatory pattern. The impulses supersede the sinoatrial node and bombard the atrioventricular node. And then, like I mentioned at the start, the AV node conducts these impulses and it can lead to a variable ventricular rate. And it's typically younger patients where they have a rapid ventricular response. So they have that ventricular rate of greater than 100 beats per minute, and then slow AF in the more elderly patients when the ventricular rate might be less than 60. So age is a very important factor when talking about AF. Um, and in this process, you have a dilated left atrium, which means there's a larger surface area, which facilitates the impulse propagation or travel of the impulse. Um, and the process is essentially maintained by atrial strain, leads to fibrosis, and then fibrosis worsens it. So it's not a particularly good pattern. Um, and factors such as elevated levels of ACE and angiotensin 2 can also worsen the pathophysiological process. So the diagram here, we have um, end diastolic pressure increases and neurohumoral changes, so nerve and hormonal changes, leads to atrial stretch, fibrosis, you know, altered calcium handling. So the fibrosis is related to the fact that there's more calcium being retained in the heart cells. And And then there's basically just abnormal atrial contractility, and this leads to the AF. And we have loss of that atrial kick. Atrial kick is essentially in late diastole when the atria contract to force the rest of the blood from the atria through the AV valves into the ventricles before systole. So you lose that atrial kick. We have that irregular rhythm, which you can feel from the pulse, and you can also pick that up on the ECG. There is a reduced coronary flow through the coronary vessels. That's why it's a risk factor for cardiovascular events such as MI, angina, etc., ACS. You can also have this excessively rapid ventricular rate, and particularly in young people. Remember that distinction between young and old. Okay, so I've got a great diagram here about some of the history features of atrial fibrillation. So let's work through it logically. So electrical signals can propagate to the ventricles from fibrillating atria and before the ventricles have fully recovered from the previous contraction. So the ventricles haven't recovered yet fully. That means there's going to be a reduced ventricular ejection fraction, an increased ventricular end diastolic volume. The contractions are going to be more forceful, and the patients can typically report them feeling these contractions against the chest wall, and this is known as palpitations. So that's the reason why patients have palpitations. And essentially, if the heart rate is increased, there's decreased clearance of calcium from the cardiomyocyte cytosol between contractions. So remember, you have that accumulation of calcium. There's increased calcium before subsequent contraction. That also contributes to an increased force of contraction, which is here, and then that also contributes to palpitations. So the fact that the end diastolic volume is larger, and also because there's less clearance of calcium. So also, if we have an elevated heart rate, there's a reduced diastolic filling time, there's reduced preload, and therefore a reduced cardiac output. That therefore means there's going to be reduced brain and peripheral tissue perfusion, and I bet you can already think about some of the complications of that. So we can have fatigue, pre-syncope or syncope, and when we see syncope, it's typically due to bradycardia after a paroxysmal episode of AF, and that's because the SA node has to take time to reset, and that can mean that the heart temporarily can't get enough oxygen to the brain, so that's why patients might experience syncope. And essentially, we can also have hypoxia causing central respiratory compensation, and that's why patients might sometimes present with shortness of breath, otherwise known as dyspnea. In a history, it's also important to ask about other cardiac problems, existing medical conditions such as, relevant existing medical conditions such as thyroid problems, diabetes, malignancy. Remember your medication history, so asking about thyroxine, social history, lifestyle history, very, very important. They could be very physically inactive. Ask about alcohol, which can increase, particularly alcohol, acute intoxication or withdrawal can increase the risk of AF. Smoking, always advise smoking cessation. Drug use and caffeine intake. Caffeine intake is also related to, I think I actually mentioned this, individuals who are susceptible to AF that can precipitate a paroxysmal episode. Okay, and always take that biopsychosocial approach to patients. Yeah, and then also the electrical signals propagate into the ventricles from the fibrillating atria, before the ventricles have fully recovered from previous contraction, can also contribute to a reduced clearance of calcium from the cardiomyocytes. Okay, let's talk about clinical examination. Again, we're going to structure this logically. So we have disorganized atrial electrical circuits. which leads to irregular fast relay of impulses through the AV node and the Purkinje fibers. Irregular faster stimulation of the ventricular contractions, and this is going to lead to an irregularly irregular pulse. I know it's a mouthful, and an increased heart rate. And this is when we have that. That'd be an example of the rapid ventricular response. It depends on how fast the electrical impulses are conducted through that AV node. Disrupted atrial kick in late diastole, so that atrial contraction in late diastole it's disrupted, and therefore there's going to be absent airwaves on the JVP waveform. So the airwaves, so the jugular venous pressure waveform, essentially the pressure within the internal jugular vein. And if you think about it, when you have atrial contraction, there's going to be some blood forced back up into the internal jugular vein, which would therefore increase the pressure in the internal jugular vein. But if there isn't any atrial contraction, it's not going to be there on that waveform. And this is the normal waveform. You can see here we have the A wave, but in AF, this wave in particular will be absent. We also have AV, atrioventricular valve annular dilation, which is where the mitral or the tricuspid valve leaflets don't come together properly. And this leads to a blowing or rumbling pansystolic, otherwise known as hollow systolic murmur. And if it's at the left lower sternal border, it's related to the tricuspid valve. Or if it's at the apex, it's more related to the mitral valve. Okay, so peripherally, because when we do our general inspection, you want to think about the underlying cause, because you might find some examination features particularly related to the underlying cause. And I'm not going to go through all them now, but it's important that you're aware of that. On your inspection, remember about a raised JVP, related to heart failure, ankle swelling related to heart failure. Palpation, when you're feeling for the pulse, it's going to feel irregular. And you might have a rate when you're basically palpating the apex beat. There may be a radial apical deficit. So essentially, the heart rate isn't quite in tune with the pulse, what you're feeling for as well. The apex beat could also be hypokinetic. It may be weak, but this is all down to the individual. And then in terms of auscultation, remember factors associated with heart failure, such as the bibasal inspiratory crackles, and also other added heart sounds such as S3 and S4. Okay, so let's talk about some ECG features. So in summary, we essentially have an irregular ventricular rate without visible P waves, so there's no P waves, therefore it's not sinus rhythm, and the atrial rate can be essentially greater than 300 beats per minute, which is very, very, very fast. Irregular rhythm, no P waves, absence of an isoelectric baseline, so we can see how it kind of follows this wavy pattern. And essentially it should follow this straight, the isoelectric baseline, which it doesn't. There's going to be variable ventricular rate, mentioned that. Typically a narrow QRS complex, less than 120 milliseconds, unless there's also a concurrent bundle branch block. Sometimes this is called atrial fibrillation with aberrancy. And in that sense, you'd have a wider QRS complex because of the blockage in the conduction system. Therefore, ventricular contraction would take longer, hence why you have a widened QRS. And you might have some fibrillatory waves, but that's essentially not too important, but don't confuse them with sawtooth waves, which you see in atrial flutter. ECG differentials, you can also have an irregular QRS complexes in second and third degree heart block. You can also have irregular baselines in atrial flutter and VFib. Loss of P waves in hyperkalemia too. In hyperkalemia, you'd also have tall tented T waves with that loss of P waves too. Other differentials, Wolff, Parkinson, White, so atrioventricular nodal reentrant tachycardia, AV-NRT, atrial ectopics, and also atrial flutter. Okay, so let's talk about some investigations, but mainly the diagnosis of AF is on clinical suspicion when there's an irregular pulse, and this can be confirmed by an ECG. And if there's an isolated episode of AF, it's important to calculate the patient's stroke risk for various reasons we're going to talk about, and consider starting some anticoagulation. Typically, the gold standard is using a direct oral anticoagulant, a DOAC, such as rivaroxaban. We're going to talk about them also more in a second. And anticoagulation tends to be lifelong. So investigations. I've mentioned this quite a few times now. I want it to be ingrained in your mind. So the fact that patients have an irregular pulse, but you may miss this in paroxysmal AF. But don't worry, there are other things we can do to detect it. ECG monitoring. So this is the follow-up after an irregular pulse, or if a pulse is regular but there's still kind of high clinical suspicion. Then on the ECG, we've mentioned this already. When you're looking at the rhythm, always measure the QRSs from the R waves. You might also have that fibrillating baseline, no P waves. It's also important to provide evidence of heart disease, if there is, contributing to the AF. So we have this also 24-hour ECG monitoring, sometimes called a Holter monitor, and this is it's very effective in diagnosing patients who have paroxysmal AF. So have these short episodes, it can pick them up because there's a longer period of recording, therefore they're more likely to catch these paroxysmal episodes. Bloods, so we have FBCs, UNEs, LFTs, TFTs, calcium, magnesium electrolytes, also blood glucose. So in terms of bloods, FBC for anemia, and PFTs. Well, TFTs too, because anemia and also thyrotoxicosis or hyperthyroidism contribute to high output cardiac failure. We know cardiac failure is related to atrial fibrillation. In terms of U's and E's, like hyperkalemia can precipitate acute arrhythmias. And then in terms of LFTs, we need to think about if we were considering starting warfarin as the anticoagulant of choice, and there's liver impairment, we might have to think about dose adjustment. Okay, and then we have transthoracic echocardiography, which can reveal information about the heart in a non-invasive fashion. Ultrasounds are, a very useful first-line imaging modality, and this can give information about pressure and also the pericardial structures. Chest X-ray can be used when there's underlying respiratory disease. It can also be used on the suspicion of mitral valve disease or heart failure. So particularly here, when we're thinking about mitral regurgitation, we can see if we follow this arrow here and we look at this chest X-ray, there seems to be some left atrial enlargement, which can be related to mitral regurgitation. It can also be related to mitral stenosis too. Okay. And then sometimes they might do a transesophageal echocardiography where they put the ultrasound down the esophagus in order to look at the heart. That's typically patients with a structural heart problem, which is found on transthoracic echocardiography. They can also use transesophageal cardiography to basically guide cardioversion, which is one of the methods to terminate the abnormal heart rhythm. Also, they might do an MRI or a CT head if there's suspicion of a TIA or a stroke. You can see here, like I mentioned, we have this left atrial enlargement. Okay, so when we think about the acute management of atrial fibrillation, we want to follow this algorithm. Okay, and I'm going to be using the term synchronized cardioversion. So synchronized cardioversion is essentially it's a type of electrical cardioversion when you place the pads on the patient's chest, the two pads, and you use that in patients who still have a pulse, um, which is the opposite to unsynchronized cardioversion. And they tend to synchronize it at the point of the R wave of the QRS complex. So first, we want to think: is the patient hemodynamically unstable? So if a patient is hemodynamically unstable, they could be in shock, could have just had a heart attack, could be in heart failure, or just generally have syncope. So if they are, you want to do an A to E approach. A call for help. You want to get plenty of people there. You want some senior input, and we want to go ahead with this synchronized DC cardioversion. If not, then we need to think about when the patient first started having the symptoms. If the onset was less than 48 hours, you want to offer you could offer rate or rhythm control, and you also need to calculate something called the Chad-Vasc score, which is basically it's a risk stratification score about the patient's risk of having a stroke, essentially, from a thromboembolic event. I'm going to touch on that when I talk about kind of the complications of fibrillating atria. If the onset is greater than 48 hours or you're uncertain, you can offer rate control plus or minus anticoagulation. Patients should typically be anticoagulated for 3 weeks at a minimum. Sometimes it's three to 4 weeks. And then you want to look at this delayed rhythm control with cardioversion, and then always remember to calculate the Chad-Vasc score. And then just to touch on the anticoagulation used in atrial fibrillation. So I've already mentioned, typically they use DOACs, or warfarin can sometimes be used. And there's a reduced risk of intracranial bleeding with a DOAC compared to warfarin. DOACs also have a shorter half-life, but the anticoagulant effects, the blood thinning effects of these DOAC, wear off within 12 to 24 hours. So warfarin is a little bit longer than that, so it's 48 to 72 hours. So you'd have to make sure that if a patient was on a DOAC, that they were going to, be adherent to that medication and make sure they remembered to take it. There's no monitoring for DOACs. They're pretty safe. But for warfarin, you have to do daily INR measurements, so it requires a bit more monitoring. And then if anticoagulation for whatever reason is contraindicated, a doctor might advise a patient to start on a combination of aspirin and clopidogrel, so antiplatelet medications. But you should never use aspirin or clopidogrel in isolation. They should be used in combination. Okay. So what we have here, we have some of the pharmacological options we can use for atrial fibrillation. And I just want to mention before we delve into this table, because I know there's a lot of information. Beta blockers typically are within class 2 of the Vaughan-Williams classification of antiarrhythmics, but there's a drug called sotalol, which is essentially a class 3 antiarrhythmic, but it's also got beta blocker properties, but it's a class 3 antiarrhythmic because it predominantly blocks potassium channels during phase 3 repolarization. So it's actually classed as a class 3 antiarrhythmic. So let's talk about rate control first. So the aim is to decrease heart rate and at rest and also during exertion. So the aim of less than 110 beats per minute. And this essentially helps to optimize cardiac output. And the indication is in patients greater than 65 with a history of ischemic heart disease. And there's various options we can look at. So we have beta blockers such as metoprolol, atenolol, bisoprolol, and these are going to act on them beta-1 receptors of the heart to essentially block the effect of these catecholamines. And that's going to lead to reduced automaticity of the SA node and reduced atrioventricular transmission, which is going to lead to a reduced heart rate and contractility. But remember, with beta blockers, bronchospasm is an important side effect because we have these beta receptors within the lungs as well. So that's important to be aware of. And if that was the case, we have these things called non-dihydropyridine calcium channel blockers, verapamil and diltiazem. So they're within the class of CCBs called phenylalkylamines, and they inhibit calcium channels within the SAN and the AVN, and they're particularly useful in asthma because they're not going to cause that bronchospasm caused by typically beta blockers. And then we also have a medication called digoxin, which is a cardiac glycoside, and that's typically used in bedbound patients where other drugs are contraindicated or the side effects aren't tolerated. And digoxin, it requires quite a lot of close monitoring, and it also has it essentially requires a lot of close monitoring, because it has quite a narrow therapeutic range, so it can quickly become quite toxic, which we don't want. But its mechanism is that it inhibits sodium-potassium ATPase, causing an increase in intracellular sodium, which causes an influx of calcium, hence increasing contractility. So therefore have cardiac output increasing without increasing the filling pressures. It also results in reduced AV conduction because it has this thing called a vagomimetic effect. Important to also mention that verapamil, like here for example, can precipitate, so it can lead to digoxin toxicity because it reduces its renal clearance. Other things what can precipitate digoxin toxicity are also particularly elevated levels of potassium. So you need to check the user needs for that too. And let's talk about rhythm control. So rhythm control, the aim is to restore and maintain the heart in sinus rhythm, so that P wave followed by the QRS complex. The indication is in patients less than 65, could be their first presentation, they're symptomatic, or if they've got heart failure worsened by AF, or in atrial flutter. So we have a drug here called amiodarone, which is a class 3 antiarrhythmic. It's indicated in structural heart defects. You'll understand why in a second. So its mechanism, it's a rapid potassium. It basically inhibits rapid potassium channels to slow repolarization, lengthen that QT interval, and it helps to conduct the action potential through the atria, through that normal conduction pathway. It can sometimes cause steatogenic changes in the liver and other organs. So it can be hepatotoxic. It's also got iodine. There's also iodine within the drug, and that can either occasionally lead to amiodarone-induced hypothyroidism or thyrotoxicosis. And this is a particularly important one for exams. It's also a P450 inhibitor. And we have this drug called flecainide now, and that's a class 1C antiarrhythmic. and its mechanism is that it's a fast sodium channel inhibitor. But if you're ever going to use flecainide, prior to the echocardiogram, it's important to check for structural defects such as cardiomyopathies, valvular dysfunction, or congenital heart disease. These can be picked up on the echo, and it's not recommended in ischemic heart disease or left ventricular dysfunction. We want to be looking more towards rate control for that. And then lastly, we have sotalol, which is the little anomaly because it doesn't quite fit into that. It is technically a beta blocker, but it's a class 3 antiarrhythmic. It inhibits beta 1 adrenoreceptors, and remember them potassium channels. That's a similar mechanism to amiodarone to lengthen the QT and conduct the action potential through the atria. But it also has that bronchospasm side effect because of its beta blocker properties. Sometimes people with AF might be referred for cardiac ablation therapy. Other things patients might be referred for is pacing. So patients with atrial fibrillation might be referred for pacing if they have symptomatic bradycardia. So back to ablation therapy. So typically there's a transfemoral venous approach to reach the left atrium. I know from this GIF here it's looking at the right atrium, but it's typically the left atrium. What is the focus? It can use radio frequency waves or cryoablation to remove superficial left atrial tissue, because ablation kind of means removal of like a superficial structure or a superficial layer, and that's conducted around these pulmonary veins in particular. You can see that there's 4 pulmonary veins, 2 from each side of the lungs, and the effectiveness depends on the severity of AF. And it's always important to continue anticoagulation depend on the CHA2DS2-VASc score, which remember stratifies the risk of having of essentially having a stroke or a TIA. It's also important to consider the CHA2DS2-VASc score when you're thinking about cardioversion, because electrical cardioversion can increase the risk of a thromboembolic event. Okay, so I've mentioned the CHA2DS2-VASc score already, and I think we'll talk about that first before we come over to the orbit score. So the CHA2DS2-VASc score assesses stroke risk in patients with AF following cardioversion. In patients with AF, or it could be following cardioversion and ablation. When there's a score of 0, you can typically do an echocardiogram to rule out valvular pathology. If you have a score of 1 in men, you can consider a DOAC such as rivaroxaban, dabigatran, whatever it is. And if there's a score of 1 in women, you don't necessarily require a DOAC. And then all patients with a score of greater than or equal to 2, you would want to be considering to start a DOAC. And in females, essentially a single point is allocated because of their sex, because of female sex in this stroke risk score. Okay. And then warfarin is if a DOAC isn't tolerated or contraindicated. I mentioned that before. And then always just consider balancing up that stroke and slash bleeding risk. So with that being said, let's have a look at the orbit score. It's a formal risk assessment for major bleeding with anticoagulation. These are just some of the factors what it takes into consideration and the corresponding points which each factor has. In your own time, I recommend that you have a look at the CHA2DS2-VASc score. You can even input some values on internet sites. That'd be very useful for you to do. And then let's look at the scores. So if there's a score of 4 to 7 in the orbit, you're at high risk, 3 is medium, and 0 to 2 is low. There are also different methods to reduce bleeding risk. patients are on aspirin and NSAIDs, you want to be stopping one of them. Important to treat uncontrolled hypertension, reduce alcohol consumption, and try to treat reversible causes of anemia, because anemia is also a risk factor for bleeding. But essentially, anticoagulation is stopped or continued depending on a whale of these two risk assessment scores. It's important to always to keep doing these regularly. But typically, anticoagulation and atrial fibrillation, if the patient's on a DOAC, it tends to be lifelong. Let's talk about some complications of atrial fibrillation. Before I delve more into the diagram, into the schematic, sorry. Prevention, we can think about smoking cessation, alcohol moderation, and then also dietary modifications as well. So let's get into this diagram. So when we have ineffective atrial contraction, this leads to blood stasis in the left atrial appendage. So it's an extension coming from the left atrium. This can lead to atrial clot formation and potentially embolization. So embolization means the thrombus or the clot dislodging and ending up somewhere else. If it dislodges and ends up in the brain, it's going to lead to a TIA, a stroke, and contribute to things such as vascular dementia. The kidney is going to cause ischemia, gut, same again, mesenteric ischemia. Remember that in terms of like an acute surgical presentation. Now, in the peripheral arteries, it can cause acute limb ischemia, which is very, very painful. If when there's a regular rapid ventricular response rate, there's a reduced diastolic filling time and hence preload. You have a reduced left ventricular end diastolic volume. There's a decompensated Frank-Starling response. And we've talked about that before as well. So it's not at that optimum level. Okay, and that essentially means there's a reduced stroke volume and hence cardiac output, existing coronary, myocardial, or valvular disease, which can also contribute to the patient potentially having a myocardial infarction, an MI. And because of tachycardia-induced remodeling and dilatation, this can present or can lead to a tachycardia, so an atrial tachycardial induced cardiomyopathy, so dilation of the atria. It can result in heart failure, and an MI can also subsequently result in heart failure too. Ineffective atrial contraction can also lead to reduced diastolic filling times and hence a decrease in preload. So preload, remember, we need that increased volume to cause stretching of the heart muscles to try and increase the contractility, but it's essentially not at an optimum level when the atria are fibrillating. And then these are just some of the risk factors for embolization complications, so such as stroke, etc. So embolization anywhere in the body, so previous stroke, mitral disease, advanced age greater than 65, hypertension, diabetes, heart failure, female sex, and also existing vascular disease. So that's everything today. I really hope you enjoyed this video. I've enjoyed doing this one personally. Remember to like, subscribe, and leave a comment. Also check out my Instagram, where I regularly post updates and also links to my notes, my personal medical school notes. I hope that you found this useful and that perhaps you learned something new. And yeah, that's everything. And remember to stay tuned for next time when we're going to be talking about an introduction to ECG interpretation. So with that being said, that's everything for today. Take care, and I'll see you next time.